Now, suppose I tell you that the preauricular mass is not, I repeat, it's not the bony mass. And on examination of the nasopharynx, there is a mass. What is now your primary clinical diagnosis? Jan, anahan?
My primary consideration is that metastatic carcinoma of the lymph node from the nasopharynx.
From the nasopharynx. Now, what will be the treatment of choice for nasopharyngeal cancer with neck node metastasis? Jan?
In this particular patient, we manage radiotherapy.
Do you have any differing opinions? Bobby, Sibulan?
Yeah, I agree.
So Bobby has the same opinion. Now, suppose I tell you that the preauricular mass is not the bony mass, and there is no oral cavity, no oropharyngeal, and no nasopharyngeal mass. So meaning there's no mass in the oral cavity, oropharynx, and nasopharynx. Now, between a parotid and a soft tissue tumor, which one will be your choice as to the primary clinical diagnosis? Can we ask Rex?
Based on prevalence, I think I would choose parotid tumor rather than a soft tissue tumor.
Do you agree, Dr. Bawa?
I agree.
Can you tell us the reason for your agreement to this statement, Dr. Bawa?
I have the same reason, that is parotid tumor is more prevalent in that area.
Now, suppose you have decided that the preauricular mass is a parotid tumor. What are the three possible causes of the tumor? Or any tumor in general, what are the usual causes of the tumor in general? Dr. Let's ask a resident from Tondo, but just pardon his voice because it's cold. He may not be, you might not be very clear in his statements, but let's try. Let's try to involve him in this conference. What are the usual causes of the tumor, Dr. Angeles?
It can be caused by inflammation, metastasis, and or benign.
Sammy, do you agree? Sammy Cristobal?
I would say these are the three: inflammatory, benign, and malignant.
Okay, follow-up question to you, Sammy. What algorithmic processes will you use to come out with the most probable cause of the tumor? We have three possible causes, right? Inflammatory, malignant, benign, or plasma. So what algorithmic process will you use?
I would use physical examination to differentiate these three.
So what else? What will happen after you do your physical exam? Sammy?
For inflammatory, if this is inflammatory, I would see for signs of erythema, tenderness, and signs of inflammation. While if this is malignant, I would look for the consistency, which is hard, immobility, and then a lymph node around the area. This benign, I would look at the consistency, which is more firm, movable, with no lymph node.
Can we ask an opinion from our side? Dr. Sok, hello? Would you like to add some more, or do you have any differing opinion?
Well, the three possible causes are the inflammatory, malignant, and benign. I agree with the Dr. from Zamboanga. The inflammatory caused by there will be erythema, tenderness, and signs of inflammation. And if you consider malignant, it is fixed, hard, with local and regional metastasis. And if you consider benign, it is so movable with no ulceration noted.
Okay, what is I don't think there are any questions with regards to the physical signs of inflammation and physical signs of malignancy. Now, what is a very reliable physical sign of benignity? Can we ask Jan?
The sign is no lymph node around the area though.
So that's an indirect way of indirect evidence, right, Jan? But can you give me a direct evidence that you may use to decide, that will make you decide that most likely the tumor is benign?
On physical examination, the one is consistency. If it is malignant, it is hard, and it is fixed. And
if it's benign, what could be a reliable sign of benign tumor?
cystic though. Cystic and consistency.
Cystic inconsistency. Do you all agree from Tondo? Cystic mass?
I would go for the fixation of the mass. If that is fixed to the skin or to the bone, that is malignant. Where if not, I would believe that it is benign. Just for the fixation.
Cystic. Cystic would also go for a benign, probable consideration of benign. But most probably I would go for the fixation. So in the absence of physical signs of inflammation and malignancy, most of all the residents agree that the next choice would be a benign lesion. Now, what is the main reason for accepting such a benign diagnosis? Bobby, Simbola?
Based on the prevalence, the location of mass is truly benign in the area.
So Bobby mentioned that it's due to the prevalence, because the benign tumor is more common than the malignant tumor. Now, suppose the preauricular mass is not a bony mass, another scenario. Suppose it is fixed to the underlying tissues. And suppose the diagnosis is a toss-up, meaning you cannot be certain what it is. It's a toss-up between a malignant parotid tumor and a metastatic nasopharyngeal cancer. I repeat, the diagnosis now is a toss-up between malignant parotid tumor and a metastatic nasopharyngeal cancer. Question: if you were to do a paraclinical diagnostic procedure, what will that be and why? Can we ask a resident from Zamboanga, Dr. Boa?
First of all, I would like to rule out the presence of nasopharyngeal CA by doing an indirect laryngoscopy. First of all, excuse me, I would like to correct my statement that I would like to do a nasopharyngoscopy.
Okay, suppose the nasopharyngoscopy is negative, Dr. Boa. What will be the next step in your paraclinical diagnostic process?
I would like to do a needle evaluation of this patient.
Which one? Of the mass